Welcome to the Explainer. Okay, so you're gearing up for your fundamentals class. You are in exactly the right place. Today, we're going to break down all those essential pharmacology terms you absolutely need to know, especially if you're diving into chapters 31 and 44. And we're going to do it by following the wild journey of a single medication, right from the very beginning to the very end.
You know, it seems so simple, doesn't it? You have a problem, you get a pill, and problem solved. But there is so much more going on behind the scenes. Behind that one little prescription is this fascinating process that pulls in pharmacology, anatomy, and most importantly, patient safety. It's way more than just swallowing a pill. Let's get into it.
All right, so where does this journey for our medication even start? You might be thinking it's at the pharmacy, but nope, we've got to back up a step. It all begins with an order, a formal instruction that kicks off this whole chain of events. This is the official starting line.
And that order, that's the prescription. It's basically the key that unlocks the whole process. Now, we usually picture a slip of paper, right? But it can be electronic, or in really urgent situations, it can even be a verbal order given directly from a doctor to a nurse. Now, before that new prescription gets going, there is an absolutely vital safety check called medication reconciliation. This is so important, especially for patients taking a bunch of different drugs, a situation we call polypharmacy. This process helps us catch potentially dangerous interactions by making sure we have a totally accurate picture of everything the patient is taking. So, the order's in, the safety check is done. What's next? Well, we've got to get the medication into the body. And you might be surprised just how many different doorways there are into the human system, and each one has a very specific purpose. For example, some routes use the membranes in your mouth for super quick absorption, like buccal administration, which is inside the cheek, or sublingual, which goes under the tongue. Others are more of a slow burn, like a transdermal disc. That's a patch that delivers medication slowly through the skin, or of course ophthalmic drops that go right in the eye. But what if you need a really direct, really fast effect? Well, that's when we just bypass the digestive system altogether. And this brings us to a huge category of drug delivery called parenteral administration, which honestly is just the technical term for giving a medication by injection. And get this, not all injections are created equal. Intradermal goes just under the top layer of skin, kind of like a TB test. Subcutaneous goes into the fatty tissue just below that. Intramuscular goes deep into a muscle, and intravenous, or IV, goes straight into the bloodstream for the fastest possible action. Each one targets a different tissue, and that changes how fast the drug gets to work. So, the medication's in. Now, the body takes over. This is where we get into the field of pharmacokinetics, which is basically a fancy way of saying what the body does to the drug. You can think of it like the body's own internal processing and distribution center. This whole process has a few key phases. First, there's absorption, which is how the drug gets from where it was given into the bloodstream. Then comes biotransformation, where the body, especially the liver, starts to break it down. And we track how long it's going to stick around using its biological half-life. That's simply the time it takes for half of the drug to be eliminated from the body.
Okay, so for any medication to actually do its job, the amount of it in the blood has to reach a certain level. This is the floor, and we call it the minimum effective concentration, or MEC. If you're below this level, literally nothing is going to happen.
But on the flip side, we have to be super careful. If the concentration gets too high, it can produce toxic effects and become harmful or even poisonous. This is the ceiling, and you definitely want to stay below it.
So the goal, the entire game, is to keep that drug level in the perfect sweet spot, right between the floor and the ceiling. And that sweet spot has a name, the therapeutic range. It's where the drug is working, but it's not yet dangerous.
So how do we actually make sure a patient is staying in that therapeutic sweet spot? Well, we measure their blood levels at two key points in time. We look for the peak, which is its highest concentration, and the trough, which is its lowest concentration, usually right before the next dose is due. This is how we know if we're hitting the target.
Now we get to the whole point of this journey, at least for our painkiller example, to relieve pain. This is the medication's ultimate mission. But to really get how it works, we have to first understand what even is pain.
Because you see, not all pain is the same. Acute pain is protective. It's your body screaming, hey, stop touching that hot stove. It has a clear cause, and thankfully, it's short-lived. Chronic pain, that's a whole different beast. It doesn't protect you, it can last for months or even years, and sometimes its cause is a total mystery. And you treat them very, very differently.
The actual physiological process of feeling pain is called nociception. It's this complex, four-step signaling process that carries the message of danger from the spot where you got hurt all the way up to your brain.
It all starts with transduction at the injury site, then transmission as that signal zips up the nerves. Perception is when your brain actually becomes aware of it, that's the ouch moment, and finally, modulation is the body's own attempt to try and turn the volume down on that pain signal. Our pain medications are designed to jump in and interrupt this pathway at one or more of these spots.
So what's in our pain-fighting toolkit? Well, the general term for any pain reliever is an analgesic. Within that big category, you have heavy hitters like opioids. We also use things called adjuvants. These are other drugs that can actually boost the pain-relieving effects. And a really key tool is patient-controlled analgesia, or PCA, which actually lets patients safely manage their own pain medication.
But look, this journey isn't always a smooth ride. The human body is incredibly complex, and sometimes things can go wrong. We're talking about everything from predictable little annoyances to serious complications and, of course, human mistakes.
Okay, this is a really important one because people mix these up all the time. A side effect is a known, predictable reaction, like an antihistamine making you feel a bit drowsy. But an adverse effect, that's an unintended and severe response. It's something that's both unwanted and totally unpredictable, a real problem.
Here's another crucial distinction you have to know. Physical dependence is a physiological state. It means the body has adapted to a drug and will go through withdrawal if it's stopped. This is not the same thing as addiction, which is a behavioral disease. That's about compulsive drug seeking and use, even when it's causing harm. A person can be physically dependent without being addicted. It's a critical difference.
And finally, we have to talk about human error. A medication error is any preventable event that ends up causing or leading to patient harm. And this is exactly why those processes we talked about earlier, like medication reconciliation, are so incredibly important. They're the safety nets designed to catch these potential mistakes before they happen.
So, from the doctor's order to the body's complex processing plant, from the intended effect to the potential for error, the life of a medication is a really delicate balance. It takes a deep understanding of the science, for sure, but also this careful attention to the individual patient. It's part science, part art. And that's something to think about before you walk into your next lecture.